Hey class, it's Dr. Dorff here. Wanted to do a follow-up lecture, this one on the heels of asthma, talking about medications that we use to treat asthma. Also, these are the same medications we're specifically talking about inhalers primarily, that are also used in the treatment of COPD. There will be a COPD lecture to follow, but I at least wanted to touch on the pharmacology because they are shared by both asthma and COPD. So quick refresher from the asthma lecture, we talked about that there are a couple of different receptors that are on the smooth muscle cells of the lungs. We talked about the muscarinic receptors, or M. We also talked about the beta receptors. And then remember we talked about in the middle of all of this that are stimulating smooth muscle, we have a bunch of inflammation going on in the middle. So once again, the M's are our muscarinics, which these are muscarinic antagonists. Remember, we're not wanting to stimulate those. For the betas, we are wanting to stimulate those. Those are beta agonists. Again, not to be confused with beta blockers. And keep in mind, we also talked about, since we're on pharmacology, that you really don't want to be giving beta blockers to someone who has asthma, because you don't want to be blocking out that beta. We want to be able to relax it. We want to stimulate it. And then with inflammation, we're going to give anti-inflammatories. Again, we aren't talking about musculoskeletal anti-inflammatories in terms of NSAIDs. We're talking about inhaled corticosteroids. The muscarinics, which we talked about in terms of receptors yesterday with asthma, and like I said, they're muscarinic antagonists. They're also commonly referred to, and you may have had experience with this on the floor already, as another name, which are anticholinergics. So we know that anticholinergics often dry things out, correct? So to be able to learn the different classes of these medications, pretty simple. Let's go ahead under inflammation and ICS for inhaled corticosteroids. So for the muscarinic antagonists or the anticholinergics, all of those are going to end in IUM. So these are medications like tiotropium, otherwise known as Spiriva, ipratropium, umeclidonium. There's also within that there is a medication called glycopyrrolate, which is really the only one in that class. So IUM and LATE. Not to be confused with latte, which you guys are probably drinking by the dozens right now as you are studying away for this class. Anyway, as we get into our inhaled corticosteroids, those all primarily end in not one, but -one. So we're talking about fluticasone or Flovent, mometasone, which is Asmanex. That's what we're looking for. They also will end in IDE or IDE, budesonide, which is Pulmicort. So with our beta-2 agonists, again, I don't want to confuse you too much with cardiac, and I don't want you to, remember I talked about you don't give beta blockers in the setting of asthma. But one thing that makes it easy from a pharmacology standpoint is similar to the cardiac medications, they end in OL. So we're dealing with formoterol, salmeterol, and of course you have albuterol. Those are your three basic classes of medications and how you're able to pretty much remember all of those by just looking at what they end in. So now as we kind of get into treatment a little bit, we're going to have, we'll divide these into a few different blocks here. Again, you know that I write like a third grader. Actually, that's doing a disservice to third graders everywhere. as they probably write better than I do. But anyway, we'll try to break this up into 3 different blocks here. So at the bottom, we're always going to have our SABAs, short-acting beta agonists. That's our albuterol, our ProAir, Proventil, Ventolin, also your Zopinex, your levalbuterol. So we'll put our inhaled corticosteroids over in this block. Remember, that's everything that ends in ONE or IDE. In the middle, we'll have our LABAs, long-acting beta agonists. Whether they're long-acting or short-acting, they're going to end in OL. And then over here, we're going to have our muscarinic antagonists, or long-acting muscarinic antagonists, or anticholinergics, which end in IUM. And then don't forget about glycopyrrolate, LATE. So we'll start with asthma. We'll put that over here. And we'll put COPD over here. So we kind of covered the stepwise approach in treating asthma yesterday. And if you remember, everyone has a SABA. We're looking at how often are they having to use that SABA a week. And then remember, we're constantly reevaluating whether we are controlled and we need to step up. So we're looking SABA 1 to 2 times a week. If we're having to do it more than that, then we need to add something to the mix. So with asthma, this is pretty simple. Asthma goes that direction. So remember, we start off with an inhaled corticosteroid. And there's a low dose inhaled corticosteroids, medium, high dose. Then we add a LABA. Remember, with asthma, you always have an inhaled corticosteroid with a LABA. You never give a LABA on its own in the setting of asthma because of increased risk of cardiovascular events. And then we save our LAMAs, I should say LAMAs. I don't want to get confused with like pictures of livestock running around. For the very end in the treatment of asthma. And again, you're able to back off. If you find that you get them to the point where they're on a LAMA, but they're only having to use their short-acting or rescue inhaler once or twice a week, then you can back off and bring it back to just the LABA with the ICS. If you get them controlled there, then you can bring them down to just the inhaled corticosteroid. So COPD goes in the exact opposite direction. It's going to go that way. So for COPD, we want to do an anticholinergic right out of the gate. You want to do a long-acting muscarinic antagonist. So again, those are because we want to dry these people out. They have lots of secretions in COPD. In asthma, we have primarily wheezing. With COPD, we have dyspnea, but we also have increased sputum production. You want to dry those patients out. So you want to use those anticholinergics or those long-acting muscarinic antagonists. So you want to be using the Spiriva. You want to be using ipratropium and umeclidinium and so on and so forth. So we start with that first. Then if they are not controlled there, and again, all your COPDers, they too are going to get their short-acting beta agonist or their rescue inhaler. If they're having to use it more than once or twice a week, then you're going to step up. You're going to add to the anticholinergic. You're going to add a long-acting beta agonist. And if we aren't controlled there, again, we reevaluate, then you're going to step up and you're going to have them on the anticholinergic, the long-acting beta agonist, and the inhaled corticosteroid. Now, pharmaceutical companies, like to combine stuff. That's how they get stuff to stay branded for a longer period of time or avoid having to fall off what we call the patent cliff. So a lot of these you already kind of know by name, but we'll say asthma, for example. There are many medications that are combined, inhaled corticosteroids, with a LABA. So let's say Advair, for example. That's fluticasone and salmeterol. Dulera, mometasone, and formoterol. There is Symbicort, about to come off the patent cliff soon, which is budesonide and formoterol. And let's see, what's one of the newer ones that's out there? Brio, the Brio Ellipta. Maybe you've seen that, or you have patients that are on that, or you use that personally. That's fluticasone and vilanterol. So it's simple just by knowing what the different classes of medications end in here. If you pick up one of those combination drugs and you look and you see what the components of, you're easily able to identify, oh, this is a ICS LABA combo. Same thing holds true for COPD. Since we start off with the anticholinergics or the LAMAs, and oftentimes we then have to step up and we have to add the LABA, drug companies aren't stupid. They've come out with medications that have both of them in there. There's, let's see, to go along with the Brio Ellipta for asthma, there's the Anoro Ellipta for COPD, which is umeclidinium. We talked about the IUM along with vilanterol. So there's your LABA combo. Brand new one that's recently out on the market, Bevespi. That's your glycopyrrolate, which we talked about here with formoterol. So again, those are just some easy ways, some easy tricks to be able to check your classes just by knowing what they end in, being able to look at your combos. And yes, in case you're wondering, they are working on medication that actually would encompass all three of these, which I'm sure will be ridiculously expensive when it hits market. So again, that's a quick down and dirty rundown on inhalers and the use of asthma and COPD. Also keep in mind that you do have your antihistamines, your inhaled nasal corticosteroids, and your leukotriene modifiers such as Singulair and Monteclast that we often are using in the setting of asthma and occasionally in COPD, but primarily in asthma. Again, hope that helps. As always, with any questions, email me through D2L or give me a call or text, and happy to go over this with you.